Okay, let's start with this portion of these PowerPoint slides with infection control. And the reason we are talking about infection control at this point is because this is one of the very fundamental principles that we will be using in throughout your nursing. And um, the purpose of this talk is not to for you to become an expert in infection control, but the purpose is for you to become aware and knowledgeable and at least reach at the applying stage of the Bloom's taxonomy. Because if you realize that we almost kind of start not at the remembering of the pyramid, but we actually start at understanding and then go to application, um, understanding, and then applying stage of the Bloom's taxonomy in our um, curriculum, and the type of questions that you see, which are NCLEX-based questions. So soon, based on what topic you learn at what stage or in what semester, soon you will be even at some of the concepts, you'll be reaching at the evaluating phase, or even well, the creating phase is usually left to a expert nurse, but at least you will reach to the evaluating phase. So I hope you know what I'm talking about when I say Bloom's taxonomy, which is this pyramid that goes from remembering to understanding to applying to analyzing and then evaluating, and at the top comes creating. But anyway, why am I talking about this here? Because uh, this is a good place to give you kind of that thought process as to how these concepts will come live into your day-to-day application of nursing process in your clinical. Okay, so um, to have a little scientific knowledge base is important in terms of what is infection, what is colonization, um, what is communicable disease. What do we mean when we say a patient or a person is symptomatic or asymptomatic? Can someone be infectious when they are asymptomatic, meaning they're not showing any clinical signs and symptoms of the disease? But yes, you have seen that. Even take this present example of what the pandemic that we are going through, people can be infectious when they are not even symptomatic, uh, and they can be going through that prodromal stage of infection, meaning the incubation has happened, but the appearance of signs symptoms has not occurred yet. So it's important to know those terms. And I think part of these terms, colonization, infection, what is a communicable disease, come from your microbiology. So again, going back, and if we don't remember, what do we mean by colonization? What do we mean by infestation? All of that it will be a good revision for you folks. Okay, so going back to very basics of chain of infection, how does infectious disease occur, and how do we spread them, and why are we, like I said, talking about this concept at this time, is all that coming into picture of why do we wash hands often? Why do we say wipe your equipments between patients? Don't take one vital signs machine to another room's vital sign machine, or don't use same cuff for one patient's blood pressure to the another patient's blood pressure. We don't use the same stethoscope unless that stethoscope has been wiped properly and disinfected properly. So all those things that we learned about washing hands, disinfecting the equipment, not sharing equipments, not sharing utensils between the patients, um, washing hands before going into the room, or what we call a gel in and gel out. rubbing alcohol on your hands before you get into the patient's room, in between while you are in the patient room, and moving out. So gel in, gel out, all those procedures are part of breaking this chain of infection. So if you are, infectious agent can be anything, any bacteria, any virus, any pathogen for that matter. Who will be the reservoir here? The reservoir will be the infected person, the patient, or it can be that Foley catheter bag, or it can be, so how can it exit? It can exit many different routes, from the patient, from the equipment, and it can go from one equipment to another equipment. We are usually, like I said in the beginning somewhere, in the previous lecture, we healthcare providers are the biggest vectors, meaning taking the pathogens from one patient to another. Those of you who might have worked in healthcare, especially long-term care settings, you might know that usually it happens one patient gets infected with C. diff, Clostridium difficile infection or something, it will spread to almost half of the unit or half of the nursing home unit. Okay, because before sometimes we realize it, it has already spread, and even after realizing, it's the carelessness of people and the shortage of staff, and there are so many factors. It's not just about carelessness. That is one factor, but shortage of staff, overworked people also are some factors. So here we are trying to see how can we break this chain. Can we break this chain at the host level? Can we break this chain at the mode of transmission level? And portal of entry can be, you through any route of you can inhale them, you can eat the pathogens through some food or wherever, if it's contaminated food or contaminated water. And who is the host? The host is whoever is a recipient of that pathogen, and that recipient can be usually a patient, and that patient then the cycle goes on, right? So you see that chain of infection, that person can spread it to someone else through something else. So here we have a couple of different places to break this chain. We have a couple of different places. First thing is, we as healthcare providers, we come across so many pathogens. Do we always get sick? No. So if your host has a great immune system, has both immunities, whether it's innate immunity or it's adaptive immunity, and both are working just fine, majority of the times we do not fall sick. We can be carriers of things, and we can have lots of pathogens sitting on our skin, sitting on our nostrils. Folks probably who work in healthcare settings with lots of MRSAs and ARSAs, we probably will be positive for MRSA, or if we swabbed our nostrils, we will be positive, but we don't get sick with it because we have healthy immune system. Okay, but here we are dealing with people who are sick, who have compromised immune system, whether it is because of the disease process that they are going through, or combination of factors. For example, medications, they corticosteroids, some may be on even drugs that actually depress or suppress the immune system because maybe they have had a sensitivity reaction, maybe they have allergies that we have put them on such things, or maybe they have had a transplant of some organ that we need to put on immunosuppressants to suppress their immune system. So there are a lot of things here, and here is the concept, a huge concept that we are trying to get across, that we can break this chain at so many different places, but still hospital-acquired infections happen. I mean, this topic, this concept of infection and inflammation is so huge that we can spend days and days. And in my patho, and those of you who might have taken patho, we spend at least a whole 3 hours just talking about inflammation. or infection, you know. And the reason I say infection and inflammation kind of together is they're kind of not interchangeable, but they have similar signs, symptoms. Sometimes it's difficult to recognize whether it's inflammation or infection. The signs and symptoms will tell you, and other systemic symptoms have to be associated with infection to differentiate between the two. So how do we differentiate that? Of course, you as a RN will not be diagnosing a patient whether they have infection or inflammation, or sometimes even the names of the disease processes are so confusing that we say inflammation, but it's actually infection. But anyway, let's not go there. We are diverting here. So anyway, here is a quick quiz. Again, I will have these questions so we can actually take a quiz on the polling system on Tuesday, and we'll go from there. Just a reminder of the infection process and the 4 stages of infection process: the incubation period, the prodromal stage, which is basically what we just discussed earlier, the stage between the incubation and before showing any signs, symptoms, the illness where you have the acute signs, symptoms present, and the convalescent stage where you're recovering, you know. So why are we thinking about normal flora? What is the point of learning about different kind of microorganisms that might be present in our unit? So be aware that we have a lot of patients on one unit, right? We have these patients who come from different places, from different type of homes, you know, in their own homes or in their nursing home, wherever they live. And our body is quite adapting. We can be very adapting to what's around us, but it takes time. Okay, so like, for example, the 2 different kind of immunities you must be aware of is the innate immunity and the adaptive immunity. Innate immunity has that very quick response, but the adaptive immunity is a little slow how it progresses. Okay, so there you have it takes time. But that's why people get a little more sick with even organisms that may not have made them sick if they were outside, or may not have made them sick if they were not in this diseased stage right now. So that's why you might see sometimes, for example, a patient may be getting sterile water when they're getting G-tube medications, or we are feeding them through gastrostomy tubes. But when they go home, they use tap water, or they use the regular, which is water with non-sterile water. And they're fine, because we usually don't eat sterile food, do we? We just eat clean food, and they're used to their own set of microorganisms that they live with, but they're not used to, and they're not as acutely sick. If they were acutely sick at home also, I think their immune system again will be compromised and will be more prone to be sick. So maintaining a nice balance of microorganisms is good, but that balance does not get maintained so quickly that, oh, yesterday the patient came here and now today. That's why we have to, like I said, wash your hands, gel in and gel out, keep one patient's microorganisms to them, don't transfer them from one person to another. And patients don't go from one patient to another patient's room. You will see physicians sitting on the beds talking to the patients, which they should not be sitting, or any other healthcare provider who might be sit on that bed. So you sit on that bed, you get up from there, you go sit on another chair in the office or somewhere else. And it's nice to be friendly. It's nice to show that you care, but there are different ways to show that you care, rather than transferring infections from one place to another. Okay. Body system defenses, and to keep in mind that body system defenses should work properly to keep you safe. If your organs are not all working in harmony, for example, if my skin is completely intact, I do not have a wound, whether it's from a surgery or from a shoe that I was wearing that was tight, or whether it was for a procedural, a diagnostic procedure that I had to get a biopsy done or something, then if I have a loss of integrity of skin due to whatever reason, I am at more risk to get infection. All the nice Staphylococcus aureus flora that lives on my skin, which usually is fine sitting on my skin, but if I have, let's say I'm shaving my legs and I get a razor cut or something, or someone is hiking and they get a mosquito bite, so that infection is usually not from the mosquito bite, but that infection is from that disruption in the skin integrity and entrance of different those outside microbes, which are fine like outside, but are causing infection when they reach the inside. All right. You all must remember the defense against infections, which the inflammatory reaction, which is part of your innate immune response to the outside agents, those agents, whichever agent that could be, any microorganism for this regard, we can say, that can cause cell injury. Okay, and these agents can be physical. For example, if you have a trauma from, or even from heat or cold or chemical agents like irritating chemicals or caustic chemicals, or there can be microbiologic agents like your bacteria or virus or fungus, or it can be at different levels, multicellular levels like the parasites, which can reach different places. Okay, majority of the time, inflammatory reactions or inflammation is usually characterized by the local symptoms, but it also does have systemic effects, but it's usually localized and you don't have acute reactions or acute effects from in each system. Okay, and when you go further, you will learn what is infection and how the infection can become systemic. And if it does become systemic, it becomes sepsis. And we are not discussing that. That is a little more complex concept that you will go ahead and learn in your third semester. I believe that's where we do that. Okay, so, but just knowing that there are different phases of inflammatory response, the acute inflammation phase, which is usually happens right after the injury and last about 24 to 48 hours, will be helpful. And why would it be helpful? Because you will be looking after patients who come from, let's say, you're on a med-surg floor, you get patients from surgery, and then whether that injury that is caused to his or her skin is intentional, because that wound, that surgeon that he incised the layers of his patient's skin and then reached into the deep tissues, is because we needed to correct his or her bone or whatever was to be done. But the body doesn't know this. The body is going to react to it thinking, oh, it's something that has been done to me and I need to react. So in first 24 to 48 hours, you may see a little angry incision, a little red. When I say angry, meaning it can be inflamed, and that is expected. So here is the application of the knowledge that you just learned. A patient is 5 days post-op and his um, um, incision is still very red and starts to smell, and patient says the exudate is actually more, it's not decreasing, because ideally when the wound is healing, you should have less exudate and the discharge should decrease in amount and it should not smell, and the angriness of the wound incision should go down, meaning the redness should go down. But in the first couple of days, it will stay angry. So that is expected. So what do you teach your patient? Do you tell them, oh, it's okay even if it's 5 days post-op? No, it's okay if it's 2 to 3 days post-op, but it's not okay if it's 5 days or 6 days post-op, or they go home and then all of a sudden their incision becomes angry again.
Yes, of course, everyone has rights to moods, but their incision does not have that much rights to mood to get angry anytime they want, you know. So all these different responses, of vascular and cellular response, how when you get injured, whether that agent, like I said, of injury is chemical or biological or physical, the inflammation response starts at the local level because the blood circulation increases at that time to that particular spot, because the body knows that, oh, I need to send more neutrophils, I need to send more white blood cells, I need to send more macrophages to that place. And then the histamine reaction, the histamine cycle starts, um, why. And that's why we keep a count on white blood cells or white cell count to monitor whether the disease is present or it's not present, or is it mild elevation of white blood cells, or the white blood cells are trending up, up, up and not going down. Even with inflammation, the white blood cells can be up a little, because usually right after surgery or right after acute procedures, folks, white blood cells might be up. And that's why we say the trend is important. What is the trend of the patient's lab? Is the trend going up and up, 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 and or is the trend going down? And then we also want to look at what are the associated signs, symptoms. Is the patient otherwise fine, or are they actually having fever? And if they're having fever, how much is the fever? How long is it lasting? Or is it like they had fever maybe for a day and then no fever for 2 days now, and their WBC is trending down? So that's something um, that is to be kept in mind. Another lab result that you will see probably is the ESR, which is a erythrocyte sedimentation rate. Okay, because um, when the inflammation reaction or the acute phase of inflammation is happening, then there is increase in fibrinogen also. So that increase in fibrinogens levels in the blood, that is responsible for increased erythrocyte sedimentation rate, or ESR, which simply tells you how quickly the red blood cells are settling out of the blood um, that we place in the tube to check it. Okay. It's not a very specific test. It's a very generalized test. Okay. Um, whether there is inflammation present or not. But mind you, when you look at the elderly patients usually have a higher ESR than their younger counterparts. So when we look at the geriatric population, ESR usually does not tell you anything, because everyone, whether they have inflammation or infection or not, their ESR is going to be up. And anyway, in general, their signs, symptoms will be so not specific. Like, for example, you might expect fever with pneumonia or UTI, and they may not show any fever. You might expect pain, but they will not have any pain. You might expect, with UTI, you will have burning or on micturition or pain on micturition. No. Guess what? Guess what they will show? They will show maybe a change in their mood or behavior. Many times you will hear those stories like, oh, Mr. So and so was doing, his usual stuff every day, and then all of a sudden he becomes so irritated and just frustrated and not talking to anyone and just doing things that he wasn't doing earlier. So, like, behavior changes. Think about that. So there isn't a whole lot of very specific sign symptoms that you can just check off on your list and say, oh, he or she has pneumonia, or he or she has UTI, or this is it's kind of a game of detective, and you have to find out what's happening with these patients. Here we have, what do we have? Mrs. Eldridge, a 63-year-old woman who underwent a total hip replacement. Kathy Jackson is a nursing student caring for Mrs. Eldridge at her home health clinical rotation. 2 weeks after surgery, she complains to Kathy that she has increased pain in her hip and low-grade fever. Kathy observes the incision and notes that it is red, swollen, and warm. And as we talked about already, I mean, if you were with me in even in Zoom or class, we would have had you look at. So here you are looking at, would you say patient already has infection or she is risk for infection? Here we go about your nursing process and your nursing diagnosis. And your brain should think like, oh, it's been 2 weeks. After 2 weeks, we should not have a red, swollen, and warm incision. It should be getting better and not should be red. And a low grade fever is also not expected. And that too in a 63-year-old person who usually does not even show. And again, there are rules and then there are exceptions. Every rule has an exception. The rule is majority of the older people have lower core temperatures. Their temperature usually drops 1 to 2 degrees from their counterparts, younger counterparts, but you will not have every patient like, oh, if it's 97 degree temperature, it's okay. If it's 99, then it's fever. Even in 97, they can that can be fever for them. So that's what we would think about Mrs. Eldridge here, and I think we go back to her after a couple of slides. We we talked about healthcare associated infections, and I'm sure you have read this in your different hospital modules, and this is a time to kind of go back and remember what we said in the beginning when we said about chain of infection and where you can break the chain of infection and why this concept is important to talk about healthcare associated infections. Patients have multiple illnesses, so they are much more at risk. 70% of our patients are older adults that are admitted in the hospital. 70% of them are 65 or older. Okay. Many of them are poorly nourished, especially when you're in the hospital. Look at the food they serve you. That's not a very appetizing food that they get. And anyway, when a person is sick, for whatever reason, many sickness, many disease processes affect the appetite. So they may not be the all well-nourished people there. Okay, compromised immune system, whether they have a immune related problem or whether they are on drugs that are causing the immune problem. Okay, here are different definitions. What is iatrogenic infection? What is exogenous or endogenous? As the names say, the exogenous is from outside and endogenous is from inside. For example, when your own flora becomes altered and overgrowth happens, let me give you one example of that. That is when someone has a GI infection and we give them some antibiotic. Those antibiotics do not distinguish. They have no discrimination system of saying, this bacteria I need to kill, rest of the other good bacteria, even though they are good for the digestion, and we have all 400 different kind of bacteria living in our gut. And that's why patients have C. diff, because all the good bacteria have been killed. Or if not killed, if they were not bactericidal drugs, they were bacteriostatic drugs. Bactericidal and bacteriostatic are different. Cidal meaning killing. So they kill, but the static just stop the growth. Either way, they can cause super infections. Super infection simply means that a patient has been all right, so continuing with the healthcare associated infections, meaning infections that usually get acquired being in a hospital setting. And like I said, you have looked at very many different modules by now. When you did those hospital related modules, there was a meaning to those as to how do we prevent those infections and the rationales behind doing all the activities that we just did, like washing hands and everything that I said before, right? And it's a very important factor because every year, if you look at just the dollar amount, and it's sad, but it is true that a lot of things, healthcare related things, get driven by the dollar amounts. For example, hospitals weren't as conscious of turning patients every 2 hours, or not inserting Foley catheter in patients who do not need a Foley catheter, or a temporary or permanent indwelling catheters, because it was so much easier to take care of a patient who has incontinence, just insert a catheter, but then the catheter associated infections are way more dangerous than someone being incontinent and maybe, excuse me, just had a lunch. um, the infections related or caused by the Foley catheters or other catheters are way more expensive than changing a patient every 2 hours, or changing their positions, or asking them if they need to use the bathroom, the 4 Ps, pain, potty, personal items, and positioning, so anyway, more nursing knowledge base that will help you getting this concept further is, how do you help a patient who has uh, skin integrity issues or infections? And I say skin integrity because we were talking about that before, and infections, it can be anywhere, but also a lot of infections that we take care of are skin related infection also, cellulitis, or wound in a infected wound, or um, whether it's surgical wound or pressure wound, or a wound caused by delayed circulation or anything like that. And what we also need to keep in mind is all these factors matter: age, nutritional status, their stress, and that stress, we are right now here, we are not talking about um, mental stress, but more physical stress, meaning, do they have other disease processes, does the patient have burns, does the patient have uh, ulcers, so what other disease processes are going on with that patient? Any compromised immune system? Because like I said, what if he or she has asthma, or they are on that 10 to 12 days of prednisone treatment, or they have some sort of inflammatory bowel disease, which has forced them to be on a corticosteroid treatment, or other factors that we said before. Now here, Mrs. Alger's wound was infected. Yes, she was admitted and received IV antibiotics, which is a very common scenario that you might come across. The wound was irrigated, or was on, she has an order for wound irrigation. She was discharged on day 4. At present, the wound remains open, but it is healing with new granulation tissue that is healthy. And I kind of leave it here because there are a couple of things that I want to focus on. One thing is, when a patient is on antibiotics and on IV antibiotics, at this stage of where you are, you need to be aware of how do I take care of a patient with, if someone has IV or any sort of IV, but at this point, peripheral IV especially, what do I look for in that IV site? The primary fluid, what kind of fluid is running, and if what kind of antibiotic the patient had, and what kind of nursing considerations I need to be aware of. Can the patient, maybe the patient can have super infection? What teaching do I provide to these patients who are on antibiotics, and that too IV antibiotics? Is it that they need to eat more probiotics? Is it that she may even go home on oral antibiotics, because after 4 days, usually the antibiotics have to be switched to oral when they go home. How do we tell the patients to finish the antibiotics? Yes, they should be finishing it up before thinking, oh, my signs have gone away, or it's not hurting as much, I should stop it. And that is one of the reasons why we have more resistant organisms in our world, or like your MRSA, URSA, VRE, you name it. Until 1950s, we did not have a MRSA because we did not have a penicillin. So where would that come from, huh? So, and what I do is, again, I almost in every lecture you will see there is this whole couple of slides on nursing process. It kind of gives you a, a clue and an idea as to when you go in the clinical, what can you use, or what kind of instruments or ideas can you use to assess a patient for different risk factors. For example, here we're talking about infection. Earlier we talked about um, um, integumentary system. Before that, week before, we talked about, in previous week, we talked about immobility, we talked about musculoskeletal system, joint problems, osteoarthritis. So each system will use the same way of nursing process. You will assess, you will uh, go to different process of, different stage of nursing process. You will, after you assess, you diagnose. So here again, you have some more ideas as to what kind of nursing diagnosis can you use for a patient who has problems in the integumentary system or the infection of any kind. Okay, why social isolation? Maybe they have an infection that is going to keep them away from other people. Maybe they have MRSA, they are in isolation, they will not be with other folks. Maybe they have vancomycin resistant enterococci. Maybe they have uh, erythromycin resistant staphylococcus aureus. So they can be, they have so many other things. Maybe they are NPO because they have to have a wound debridement done. So that's why impaired oral mucous membranes. So here, just kind of giving you a couple of ideas as to how, in what details should you assess your patient, and what kind of nursing diagnosis can you use for your patient. And what would you plan? This nursing process will not leave you. You will be using this nursing process. And like I said, some instructors may be using each week's system that we are learning in your care plans. And some instructors might be saying, let's just go priority wise and prioritize our nursing diagnosis and see which nursing diagnosis is of more priority, or 3 nursing diagnoses that are of more priority for your patient. But this is the place, these 16 weeks is when we learn that yes, each and every system is important, and each and every system has the same kind of process going through. And then you prioritize whether pain is the priority for the patient, skin integrity is the priority for the patient, immobility is the priority for the patient, risk for infection is the priority for the patient, or pneumonia or fall or whatever it is. Okay. So how you set your goals, no one gets to their goals without teamwork and collaboration. Do you collaborate with the social worker? Do you also collaborate with the case manager? Do you also collaborate with the physician, the pharmacist who is getting their medications ready, physician whom you are informing if there is a change in patient status? Do I tell a physician 2 days after surgery, like let's say yesterday evening at 7 p.m., the patient came to the unit after the hip replacement, and then about 36 hours later, I worry, oh, patient may have mild grade fever at that time. Patient may have a little bit of, in fact, the WBC may even go higher from the time, because they do a pre-op level and then we do a post-op, and you say, oh, they didn't have the WBC this high, but now it's a little high. After that, that is expected because the inflammatory process is settling in, and that will take 24 to 72 hours, or sometimes they say 24 to 48 hours. It may take up to 72 hours. That you should be worried about. Then you should be worried about a patient's incision and infection settling in, and what type of, is it serosanguinous, is it sanguinous, and we should talk about how do we define those different kind of discharge from wounds. Okay. And what would you teach a patient about infection prevention and control? Meaning, keep the wound clean, even though you were okay not taking shower maybe every day, but maybe now you do need to shower every day. Maybe someone is used to taking showers every other day, and it's okay because their skin was so dry. But now even the normal, what we call normal flora, is that is on the skin, and that is okay if it's outside the skin, but if it gets into the incision, that's a problem. Clean dressing, how to change the dressings, how to keep the dressings not face down but face up, those kind of things. How do you implement all this teaching that you just did? You are preventing and promoting health every time. You're telling your patient, wash your hands before you eat, wash your hands after you, if you happen to touch your wound or something. In acute care settings, we are trying to break that infection chain all the time. We also need to touch upon aseptic or sorry, asepsis. Okay, what is asepsis and what is medical asepsis and what is surgical asepsis? Part of it you will also learn in your lab when we teach you how to open a surgical or a sterile container, how to open a non-sterile or just a clean container. For example, when we do oral suctioning, like with that Yanker that you guys learned in the beginning, that is a clean suctioning. That is not sterile because you are using that Yanker for almost, if not the 24 hours, but at least a whole shift, depending on what the protocol is of your hospital. But if you do a tracheostomy suctioning, you're using tracheostomy suctioning kit each time. And you're throwing it away, you're not reusing it. Same way, when you are straight cathing a patient or straight catheterizing a patient, meaning each time you are inserting a catheter in suprapubically into their bladder, that's a sterile procedure. Patient may go home and they may do it in their home without sterile gloves and all, which is fine because like we said in the beginning, they are used to their own flora and they will not be infected. But in the hospital, the floras are different. It's everyone's flora all together, so the difference between cleaning and asepsis and disinfection, that is literally a revision for you from your microbiology. Okay, how to wash hands, how to make sure that a surface that is supposed to be disinfected is disinfected, and sterilization is different. Disinfecting is not killing the bacteria, but it's eliminating the microorganisms as much as possible. And in disinfection, if there are spores, they will be present there, but they will not be completely gone. But in sterilization, the difference is there is complete elimination or destruction of all the microorganisms, which includes the spores also. And how do we sterilize? Sterilization is not just wiping a surface with disinfectant wipes and all. Sterilization happens in very many different ways. And that is not something that you have to learn at this point of time, but eventually somewhere, if you get into a specialty or something, how there are autoclaves, there are ways to sterilize a syringe or the equipments that they use for surgery, all the equipments that you used in a surgery, all the scissors and forceps and everything, they don't get just thrown away. They get sterilized. And those packets and how to keep the packets sterile, that will be part of one of these labs that you learn before your second exam. And we make sure that you learn to how to open a sterile packet. And we can sit here and just talk about these. I'm just going to show you these steps here. Hold on. But the surgical asepsis, only when you get to open a packet and see what do we mean when we say 1 inch around the outside periphery is not considered sterile, but the inside is sterile. So that will make sense only when you open a sterile pack in the lab and you see where the content is placed and why the outside is considered, or the periphery 1 inch is considered clean but not sterile. Okay, so going back here again, the isolation part, you learned how to put on the isolation garb, you learned how to put the mask and gown and gloves and everything, and how to take them off. Why do we also need to talk about different kind of isolation precautions? What do we mean by airborne, droplet, or contact, or isolation? Is it will also always depend on what kind of disease the patient has. Is it something that spreads through airborne particles? Is it something that spreads through, droplet? For example, we were so confused, and probably still are, about COVID, but maybe not as much now. That first we thought, oh, it was droplet. Then we said, oh no, it's airborne. Oh no, it's droplet. Whatever, right? Then there are disease microorganisms like MRSA, URSA. They are contact, meaning, or C. difficile. That means you have to come in contact with those. You don't breathe them in. But airborne or droplet is something you breathe in. Droplet are bigger drops that you person can cough or sneeze up to 6 feet away. And airborne is like your infection, tuberculosis infection, which usually your patients will be in the negative pressure room. And at this stage, we are not going into airborne precaution rooms. So I'll make sure that when we meet for our team meeting this week, which is either Monday or Tuesday, your instructors are aware, and you should be aware too, that we are not going into airborne rooms. And because of shortage of PPEs, anyway, majority of the hospitals are not letting us go into isolation rooms. But if you do go in the isolation rooms, please make sure that you have the proper gear, and you know what kind of isolation is it. Is it because your book does a great job. It has a table that talks about what you should wear and what you don't have to wear based on different types of isolations. And then keeping in mind that isolation has psychological implications too, because the patient themselves may feel very isolated, that everyone comes here all geared up, even though nowadays everyone is wearing mask anyway. So whether the patient is in isolation or not, we are all wearing masks. But before year and a half or so before it happened, we were not wearing masks in every patient's room. So right now, I think everyone is kind of in that mindset, but it was more applicable when we were not in COVID. I don't know how else to put it, but anyway, from the thinking from the patient's side, thinking from that patient's eye, or looking through the patient's eye, always focusing our care on patient, because we go by QSIN. And if you have not heard QSIN by now, you hear it now, and you'll hear it again and again. Quality Standard Education for Nurses, QSIN. QSIN is a framework that we use, just not we did not invent it. Someone somewhere in North Carolina started it many years ago, and all the nursing programs or all the nursing curriculum had to be adapted. That was in 2007 2008, when all nursing programs had to adapt to the QSIN framework, which actually gave a national standardized education for nurses. So we have these 6 standards in QSIN. First one is patient-centered care, and everything that you might see, and you see that we always talk about through the patient's eye, and team collaboration, and informatics, communication. All of those parts are parts of the QSIN that we always focus on. So whether we say it explicitly or not, our curriculum is based on those standards. And that's why you keep seeing all this nursing assessment, the implications, diagnosis, NANDA, all of that part, all be focused on patient-centered care with collaboration with team members. Again, nothing fancy here on these slides. What is surgical asepsis? You read it, you get it. Okay, there is nothing that I need to focus on in particular, but I do need to let you know that these last couple of slides will make more sense once you maybe open a sterile wound dressing pack, whatever that is, whether it's it doesn't have to be a surgical equipment set. It does not, you don't have to be in the operating room and be a scrub nurse to know what surgical asepsis is. We used to have the OR rotations through most of the hospitals so that you actually get some experience with that. But I don't know, with the situations we are in right now with the pandemic, majority of the hospitals have said no, even though we are there on the units, but the ORs have said no. But we'll keep trying and go from there. Okay, and like I said, all of this will be just one lab of how to open a solution, sterile pack, how to prepare a sterile field. All of this is part of the lab, not here. I mean, this is not something that we can talk about and just understand. No, always evaluate whatever you're doing. And the best evaluation is, did you achieve the goal? Did you keep your patient safe? Because the whole idea is keep the patient safe. Not, the safety does not mean just the physical safety of, oh, patient did not fall, and patient, the safety also means patient did not get a pneumonia from being static in the bed. Patient did not get a pressure injury. Patient did not get infection or further infection, or the infection did not spread, or we did not have any more, or we did not pass on the hospital acquired infections that patients are very much at risk for. You know, no one got a UTI while being here, or my patient did not get a pressure injury while being here, or patient did not get a UTI while even they had a Foley catheter. So please make sure that you are keeping all that in mind, and that wraps up this part.